So a bone density may be necessary if the x-ray is showing a break or bone loss in the spine. So just based on that x-ray alone, they may show osteopenia, but it may not actually correlate with what we see on the bone density. Back pain with a possible break in the spine. If they're unsure, just go ahead and get the bone density, because perhaps we can prevent further decay or fracture of the bone. Height loss of a ½ inch or more within 1 year, and that can be based on, did they stretch enough or not? We always have discrepancies in height, and I have more conversations about that than almost anything in the office. But if they're losing a ½ inch of height and they've really stood correctly, it may be necessary to get a bone density, especially if they've had an incident. Ask them, was there a particular time that you had a lot of back pain and maybe something happened but they didn't go in for evaluation? And total height loss of 1.5 inches from the original height. As we get older, we all shrink. The disc spaces in between the bones gets thinner, but 1.5 inches is quite a change. Next slide. And it's recommended that we do the dual energy X-ray absorptiometry, DEXA, and it's DXA. Of the hip and the spine, and this is international standards. We in our office always do the left hip because the left tends to be the weaker side of a person, and the spine, L1, 2, 3, and 4. They are the sites with higher fracture rate and complications if they fracture those areas. The pain and the recovery is longer, and they had to develop an international standard, and that's what they came up with. Occasionally, we will do the distal 1/3 radius of the wrist if we cannot do one of the others, or if there's a problem with hyperparathyroidism, we'll do a wrist. You have to have at least 2 vertebrae to do a bone of L1, 2, 3, and 4. At least 2 of those have to be evaluatable. Next slide. And so this is how we categorize bone density. And we all know this, but patients actually spend a lot of time with me reevaluating exactly where they are in the osteoporosis range. Is it severe osteoporosis? And I remind them the definition of severe osteoporosis is a low T-score of -2.5 or lower, and they've had a fragility fracture. So for example, I saw a person yesterday who had a T-score of -4, but she hadn't had a fracture yet. So she's not considered severe, but I'd be very concerned that she would fracture eventually. And in between is osteopenia, but people in the osteopenia range do fracture. And I remind the patients, at some point, they had to decide where is osteoporosis, and they decided it's at -2.5. So some people will fracture at higher levels, and some people will fracture at lower levels. And so when we have the patients coming in with a chronic kidney disease, their age is factored into that. The femoral neck is factored into it, but the spine T-score is not. So if you don't have the T-scores and you don't have a fragility fracture, we do use the FRAX, and we use it quite a bit in our office, but we don't let our bone density techs do it because the patients get confused as to if they have rheumatoid arthritis or osteoarthritis is the biggest thing. And a lot of those questions you have to gently ask them on the FRAX score. So we don't have the machine do it. We ask them in the office and calculate it on our phone. But as a reminder, if your FRAX score for anything major greater than 20% or the hip greater than 3%, you're at risk for fracture and should be treated with a medication proven to reduce the risk of fractures. Next slide. So the clinical diagnosis of osteoporosis in specific populations, elderly, without known reduction in GFR, can be made by low trauma fractures. Once other causes of the fragility fractures are excluded, such as osteogenesis imperfecta, and we talked about T-scores, but OI is one of the most common things we see. As yesterday, I enjoyed the talk actually on the hypophosphatasia. We do see those patients as well, and I appreciated that talk. Next slide. So osteoporosis, bone strength is a composite of bone density and bone quality. And when a patient comes in and they say, well, I've done everything, I've had a good diet, I've exercised, I tried to do better this past year, that's why I didn't want to take anything last year when I saw you. I have to really sit down and remind them again, it's not your fault. You know, the bones turn over, and this is how I explain it. Before menopause, your bones are working along well. The estrogen keeps them in balance. But once you hit menopause, those osteoclasts are breaking down bone faster than your osteoblasts can build it, and it takes a medication at that bones, that cellular level, to control those osteoclasts, put them back in check for a while, so when your osteoblasts build bone, your body can keep it. And yes, it is real bone that these medications are building. Your own body is building I take this back. Your own body is building the bone. The medications are not. So there's many factors that go into development of osteoporosis. You know, calcium, vitamin D, phosphorus levels, the PTH, celiac disease, and we take a look at all of that when we're evaluating a patient. Next slide. I have a picture similar to this from the New York Times in my office, where we have a picture of one person that has a normal bone. The next is osteopenia, and the next is osteoporosis with holes in the bone, so people can really visualize what it looks like. What are we treating? Because you can't see the bones. And people will say, well, my hip hurts. Is that where I have osteoporosis? No, you don't have pain until you break the bone. Otherwise, it's likely osteoarthritis, musculoskeletal soft tissue issues. And so we have to explain really to them the importance of treating the bone, because a lot of people don't get it. They just read the complications of medications on the internet. But we remind them this is a silent disease, as is kidney disease. And that's why you have to take a look at these, and when they're abnormal, seriously consider treatment. Next slide. So what's the prevalence of CKD in the US population? This is an old number, of course, 99 to 2004, but it hasn't changed that much over time. So in persons 60 years of age or older, 39%. CKD3, defined by GFR of 60 to 30, represents the greatest portion of these people, and we see a lot of these people. Fortunately, we can use our medications up until people get down once they get to 35, and definitely that's our cutoff for prescribing these medications. But ahead of that, we can still prescribe medications to help their bones. It's more common in non-Hispanic Blacks, Mexican Americans than non-Hispanic whites. And more common in diabetes and people with hypertension. So I actually discuss weight management in our office because of these complications that are going to happen eventually with the kidneys. And also we actually have people that if you are overweight, you don't control your body as well, and you may tend to fall more, resulting in fractures. So we actually discuss all of this to an extent in the office. Next slide. National Health and Nutrition Examination Survey did a study. 20% of patients with osteoporosis had CKD 3% had GFRs of less than 35. And that's where the osteoporosis management is much more complex. We have to be very careful with our medications because their ability to metabolize and control their calcium level changes. The parathyroid hormones change with chronic kidney disease. They may have abnormal calcium, phosphorus, PTH, and vitamin D levels. Next slide. So the clinical risk factors for osteoporosis in chronic kidney disease, we ask patients all of this information as they come in. Had you been on heparin chronically? And it's specifically heparin, not so much the other blood thinners. Steroids, of course, you know, an injection of steroids occasionally for epidural steroid, knee joint injections are fine. Short courses, very short courses occasionally for asthma, but if you're chronically needing medications to control the asthma, that's considered chronic steroid use. And of course, in many of the rheumatologic conditions, lupus, rheumatoid arthritis, and such, since we're using DMARDs and biologics, and also Crohn's disease, we have seen a lot less complications of the steroids, but many of those people still do come through our office. If they are being treated with androgen deprivation therapy for prostate cancer, if they're receiving aromatase inhibitors for the breast cancer, those are risks for developing the osteoporosis. Of course, poor nutrition over time, if they had a period of time of anorexia or other eating disorders, if they did not have adequate amounts of calcium over time, if they're vitamin D deficient, and the patients also a lot of times say, well, I was out in the sun all summer, so I stopped my vitamin D, or in the summer, I take half the vitamin D level. But honestly, when we check blood tests, if they decrease their vitamin D intake by mouth, we see drops in their vitamin D. The sun isn't always predictable, and I remind them we don't want them sunbathing. We don't want you to get skin cancer. It can be easily fixed by a little D3, 2,000, 5,000 IU pill or ergocalciferol. That's how we prefer to fix the vitamin D levels. We check, of course, for hyperparathyroidism, and if it's abnormal, doing the scans, finding which gland's abnormal, referring them to the surgery to get that fixed, wait a year, then recheck a bone density and see how they're doing. And of course, metabolic acidosis as well. These patients are also treated in conjunction with the nephrologist. Next slide. Chronic kidney disease abnormalities. Altered metabolism, as we spoke about some. Again, these are some of the labs that we check. And we abbreviate this, I think, ongoing CKD, BMD, bone mineral density to save room. Systemic mineral metabolism derangements associated with increased morbidity and mortality. We've already touched on some of those. Next slide. And I have to tell you, I had a lot more slides, actually. I had to print these out and put them on my dining room table. My son came down, he said, what are you doing? I said, I have too much information here. I have to calm it down. And he looks at me, he goes, well, you could have connected your computer to your TV, then you could have moved the slides around and saved paper. Anyway, this is how I did it though. So with the bone physiology abnormality, you're looking at the bone turnover, and there are certain lab tests that we look for that. There are other ways to gauge the physiology of the bone. We're going to talk a little bit about doing bone biopsies to decide the bone turnover. Those are more done in the later stages of chronic kidney disease. Sometimes we have people that come in that just really, their kidneys are fine, but we're not sure exactly why they have lost bone over time, and some of those patients will also do bone mineral densities. The vascular soft tissue calcifications, I actually had a person in yesterday, and she had finally, she had a non-healing fracture of a lower extremity, chronic smoker, and she had a FemPop surgery, and all of a sudden her legs started feeling better. I said, aha, now maybe this time if we go in and treat you with one of the bone stimulating medications, abaloparatide or teriparatide, and the surgeon does the fusion, it might actually heal this time. So making sure that they have good circulation to the lower extremities, otherwise they may not heal so well. Next slide. So the stages defined of chronic kidney disease. A stage 1 greater than 110 with evidence of intrinsic renal damage. Stage 2, evidence of intrinsic renal damage. Stage 3, 30 to 60 to 30. Stage 4, 30 to 15, and less than 15 is end-stage renal disease. So a lot of our patients with kidney disease, they are referred by the nephrologist. It gets to the point where we can't do so much with our medications, but more letting them know where they stand in their bone mineral density, letting the patients know if they're losing bone over time. We'll see a lot of those people. Next slide. And this is just another definition of chronic kidney disease and the potential complications that go along with it, which can make the issues of osteoporosis worse. Anemia, of course, blood pressure increases or decreases. You get that syncope, more at risk for falling. Calcium absorption decreases. You can't give these people too much calcium because they can go on to develop, and I forgot the word for it, but the calcium can actually sit in the tissues and cause very large sores. I had never seen this except for in a relative of mine, and it was quite traumatic. So we have to be very careful with how much calcium these chronic kidney disease patients are receiving. You know, the calcium, this is also a question that comes up all the time. 1,200 milligrams is what's recommended for men and women age post-menopause, age 50 and older. And that it really is, I tell them, that's food plus supplements is 1,200. And so often I'm actually decreasing the amount of calcium that people are taking because they are getting it in their food. And we actually have a list of calcium-containing foods that we go over with them in the office. So they need to be careful with that. Hyperkalemia, hyperparathyroidism, hyperphosphatemia. Next slide. So the average estimated GFR decreases over time, and the more accurate calculation that we use is the Kraft-Gault equation. That's considered the standard. So if with that their chronic kidney disease is too low, then we will change our therapy based on that. So on all of our patients, we are checking the calcium, creatinine, and vitamin Ds before we administer certain medications. And we want them done, the calcium and the creatinine, within 30 days of the infusion, because kidney disease, kidney levels can change over time. And so we want as close to the infusion time as possible, knowing what the calcium levels are. Next slide. Fractures in chronic kidney disease, again, due to hyperparathyroidism, there can be adynamic bone. And we don't know if they have high bone turnover or low bone turnover. Are their osteoclasts suppressed? If they are, then of course we don't want to give them a medication that suppresses osteoclast. Osteomalacia we see so frequently. Their vitamin D levels are low. Their bones are just aching to have more calcium, but they can't get it because their vitamin D levels are too low. So we frequently see this. And the osteomalacia, again, these people are being treated in conjunction with a nephrologist, so they may be making changes. So we try to have that as open communications to know what each of us are doing with the patients, because quite frequently these patients, they're confused. They're not sure what's going on because of their mental state associated with the chronic kidney disease. Post-transplantation, their kidney functions have improved. They're approaching better bone turnover. So that changes what we do with these patients then. However, they're probably on 5 milligrams a day yet of prednisone. So taking all that into consideration in determining what medication to use. And sometimes it is just simply watching the bone mineral density over a year, maybe 2 years after that transplant to see how their body adjusts and takes care of it. And if they come into chronic kidney disease already with the osteoporosis, like I said, that is problematic. So that's why we really like to treat patients earlier in their life, right after menopause, start looking at their bones and adjusting as needed, so that they go into older stages of life with the best bones possible. Next slide. Diagnosis of osteoporosis in populations with known GFR is the same. You can't use the WHO diagnosis exactly on treating these patients. Everything changes and everybody's an individual. You have to look at the histomorphology differently. Next slide. Okay, and then of course, like I said, in CKD5, the fracture risk is very high, about 50% prevalence of fractures. There was actually, I saw the other day, EULAR 2020, which is the European Union looking at chronic kidney disease. And one thought is one of the best treatments for chronic kidney disease is to do nothing, but that's not always the best treatment. The risk factor increases according to the stage of CKD, with those on hemodialysis having 3 to 4 times more fractures than the general population. And I'm going to talk about non-medication treatments in just a little bit, but remembering the most important thing for these people to do is that they should continue to exercise. They should be up on their feet, walking around as much as possible, taking adequate amounts of vitamin D and calcium, not smoking, and the calcium more in the food. Next slide. So 1 year mortality after a hip fracture in CKD is about 60%. It's life-changing. Even in patients that don't have CKD, having a hip fracture is life-changing. A lot of people don't want treatment because of the fear of side effects until they know of somebody that one of their friends had a hip fracture and they ended up in a nursing facility or died because of the hip fracture. Age-matched controls, 15% of female, 30% of males. So actually more males have chronic complications of the hip fractures. Next slide. So CKD BMD describes a wide range of systemic mineral metabolism derangements seen in CKD patients. Renal osteodystrophy, it's various abnormalities in bone and histomorphology can occur, which disrupts the bone turnover, like we said. So one of the biggest, so I'm going to review with you one of these case studies that I had. I actually saw this person back recently, and he was one of the reasons that I decided to do this. So I'll read this to you. Mr. returns for follow-up of low bone density and renal osteodystrophy. Saw him for the first time last year. His bone-specific alkaline phosphatase was 15.1, suggesting low bone turnover. He had end-stage renal disease and on hemodialysis for the past 2 decades now. And he was taking Sensipar. Sensipar is a medication that helps to regulate the calcium metabolism, but can only be given to patients who are on hemodialysis. He was not taking his weekly vitamin D. Again, not sure where the communication was between the nephrologist and him. He was seen by his primary care provider who had recommended Prolia because he had had this worsening bone density, but because of insurance concerns, it wasn't given. And so he came in to see us. He has chronic teeth decay, which is very common in many of these patients. Poor balance, you know, he's been on dialysis for so many years. His weight has been decreasing. Down 16 pounds a year ago. I saw him yesterday. He was down another 14 pounds. And so the bone mineral density had a 7.5% decrease in the femoral, in the hip. Femoral neck was a -2, which wasn't too low, but we're concerned that it is decreasing over time. Some of these decrease in bone density could be explained by the weight loss, which falsely lowers the bone mineral density reading without a true change in the mineralizations. But in patients with dialysis, they can have several types of underlying bone disease, such as adynamic bone, osteoitis, fibrosis cystica, or high bone turnover. And so we wanted to do a blood test called a bone-specific alkaline phosphatase. It is one of the few laboratories that we can check that is actually useful in chronic renal patients. Unfortunately, we did not get that result. So yesterday, I reordered the test. We didn't get the labs that we had requested. And of course, we did not want to give him a denosumab because he is a dialysis patient. There can be secondary hyperparathyroidism, so he cannot correct his transient hypercalcemia associated with the administration of the denosumab. He is at high risk for significant prolonged hypocalcemia. We could possibly use what's called recidronate low dose. That has actually, there was a study that was done. It showed it was safe, but we had not started that last year. And he was going to have his labs drawn at his primary care, which I don't, you know, I understand. He already has problems with the shunt in one arm and difficult to stick. So we said, get your labs done elsewhere. But one of the biggest problems with these patients is that they don't follow back up with us later on. Next slide. So what we're looking for when we're doing these labs, though, I want to know what his parathyroid hormone is right now. What is his vitamin D level right now? Could I be giving him a little bit more vitamin D to help him? And this all stems, the problem with the fibroblastic growth factor, FGF23. It's a hormone that is regulated by the kidneys, and it is responsible for throwing all of these functions off with chronic kidney disease and disrupting the bone metabolism. Next slide. So like I said, these are the chemical parameters that we check: calcium, vitamin D, phosphorus, PTH, and intact PTH, which is a better evaluation of the parathyroid. Now, back to the bone-specific alkaline phosphatase. This is a lab. We do it at Barnes, but it's kind of difficult sometimes to get this ordered. I had to talk with a lab medicine resident to let him know, yes, I do work in bone health, to get this done, because they don't always quite want to do this. They don't want patients ordering it too much. It's a more expensive test. If the alkaline phosphatase is sufficient, they want you to do that instead. But with this kidney failure patients, we really do need the bone-specific alkaline phosphatase, and that helps us decide. It's one thing to help us decide if the bone turnover is too high or too low. Next slide. And one other thing, though, about the calcium levels is that, quite frequently I will see patients, yes, we don't want their calcium levels too high, but they end up being hypocalcemic. Quite frequently, I will see labs that their calcium levels are about 7.8 when they came in to see us. Maybe they just had dialysis the day before, I'm not sure. But they should have a little bit of calcium, something to feed their bones. Otherwise, they do develop worsening osteoporosis. So this is just a characteristic example of the bone turnovers, all of the things involved in the bone turnover, its guidance for future therapies of bone, medications. Next slide. So specifically, the parathyroid hormone is a peptide hormone synthesized by the parathyroid glands. PTH increases the concentration of calcium in the blood plasma. So if you have high PTH levels, your calcium levels go too high. If your intact PTH is the biologic active form and is secreted when the calcium levels are too low. I think I said this backwards, hold on. The IPTH is eliminated from the calcium after half-life of less than 4 minutes, so it has to be done very quickly when drawn. Next slide. And then the bone-specific alkaline phosphatase, I already spoke about this. It's a biomarker, the bone-specific isoform of alkaline phosphatase. It has been shown to be a more sensitive, reliable indicator of bone metabolism. Next slide. And then again, in CKD stages 4 through 5, they may have high bone turnover. And we do check, the lab test that we sometimes check on patients coming into our clinic, if they've had long-term use of bisphosphonates, if we're not sure why they have bone loss at an early age, we will check alkaline phosphatase levels. Osteocalcin and beta-CTX, though, those are markers of bone turnover that we do use, but they're not helpful when in chronic kidney disease patients, since they are cleared by the kidneys. So they could be quite abnormal, but they really don't tell us anything. And an elevated bone-specific alkaline phosphatase excludes adynamic bone. We check the vitamin D levels again. Next slide. Secondary hyperthyroidism, a low 25 hydroxyvitamin D, hypocalcemia, calcium malabsorption, or poor intake of calcium. A lot of our bariatric or gastric surgical patients for weight loss, they have a problem with vitamin Ds and calcium. Some of them require a much higher intake of calcium. They may have high PTH levels and chronic low vitamin Ds after they've had the surgeries. And so for some of these patients, we do have them on high vitamin D and calcium. We look for hypercalciuria and fix that if needed. Next slide. What is osteomalacia exactly? It's abnormal mineralization with low bone formation rates resulting in reduced bone disease and weakness of the bones. A lot of these patients can have a lot of achiness, pain. You start to fix their vitamin D levels, they get enough calcium in the bones, and they start to feel better, similar to what was discussed yesterday with the hypophosphatemia patients. The results of vitamin D deficiency may be caused by a lack of calcium and phosphorus, if they're just not getting enough of the vitamins in general. Some cases involve the presence of a tumor in the body, the fibroblast growth factor, FGF23. There is a scan that is now available that we do. It used to be very hard to find these tumors, but recently there is a new scan that we have where we can isolate these tumors, and the surgeons could go in, remove these tumors, and all of a sudden the patients can absorb minerals correctly, and they feel so much better. They maybe had originally been sent to us for bone loss, and we start to find these tumors. They're rare. We get maybe 2 or 3 a year. People that have been housebound have higher chance of developing osteomalacia. Again, they just haven't been outside. Sun isn't always an indicative factor, but that can be a factor in it. People with that celiac disease and consuming gluten, they of course have onset of osteomalacia due to their abnormal absorption of vitamins and minerals. Next slide. So in bone denormalization in CKD, the calcium phosphorus levels are thrown off. Excessive amounts of phosphorus in the blood causes an increase in the PTH, and so that's where it's the nephrologists who are administering the phosphate binding medications as needed. Increased PTH stimulates the excretion of calcium from the bones, and then both osteoporosis and renal osteodystrophy independently increase bone fragility. Next slide. So the types of renal bone disease: high bone turnover, osteitis fibrosis, secondary hyperparathyroidism. Low bone turnover, you get adynamic bone, it's just not turning over. You can get a combination osteoporosis, osteomalacia with the low vitamin D. Severe hyperparathyroidism can result. You get high bone turnover. Bone turnover is also low in combination with increased volumes of unmineralized bone, osteoid bone. A mixed uremic osteodystrophy. You get elements of both high and low bone turnover. Next slide. So bone disease and CKD, differentiating between osteoporosis and CKD. So in CKD stages 1 through 3, bone has a low bone mass or fragility fractures. Osteoporosis more likely than CKD BMD. So the osteoporosis is more likely due to postmenopause, underlying conditions. But with CKD stage 4 or 5, the bone biopsy may be necessary to differentiate the different types of bone disease, including osteoporosis. Next slide. So how do we do a bone biopsy? This is something that's done by our bone specialist. You know, we do have some patients that have other cancers or such, and they'll say, well, I had a bone biopsy, but that's not telling us exactly what we need. So it's considered the gold standard for diagnosing of a renal disease and for defining the bone turnover activity. It's hard, though, to get patients to consent to do this because it is quite an ordeal to do. So it requires double tetracycline labeling for quantitative bone histomorphology. So the staff actually has a formula that they give them where they take a tetracycline for a number of days, and then they don't take it for a couple of weeks, and then they take it again for a few days, and then they do the bone biopsy. And what they're doing is they're looking for the movement of that tetracycline on the bone biopsy, and then the pathologist will give us reports of whether the bone turnover is high, normal, or low, and that helps us determine which treatment to use. It is a safe procedure to do, very low morbidity. It does hurt, but most patients do well with it. Next slide. And again, the results can be, this is the results that we get. Is it normal bone? We can osteoitis fibrosis, mixed osteodystrophy, low bone turnover or osteomalacia, or adynamic bone. low rate of bone formation and reabsorption, in which cases we know for sure not to give them one of the medications to slow bone turnover. Next slide. In high bone turnover, we'll see abnormal collagen deposition, marrow fibrosis, high rates of bone formation and reabsorption, but this often reflects secondary hyperparathyroidism. So again, correcting the hyperparathyroidism is the first course before prescribing a medication. Next slide. Fracture prediction, like I said, in CKD 1 through 3 can be used by DEXA, but DEXA is a poor indicator to discriminate between fractured and non-fractured patients with CKD 4 or 5. And in CKD 5, there's no difference in BMD, bone mineral density by fracture risk. So high rates of fracture is seen normally in this population. So that's where we have to talk about other factors to reduce the risk of fractures, primarily not falling. Next slide. So this is a CT image of more of a characterization of what bone looks like. The patients want to know what's going on exactly. We describe it kind of like the girders in a building. The fewer girders, perhaps the more likely the bone is to collapse, and that's the building is to collapse, and that's what happens with the bone. The girders get thicker, there's fewer of them, and then the ceilings can start to cave in. And so again, understanding that this is what's going on in the bones, you can't see them just looking at yourself, but when they start to get this conceptualized picture of it, then we know that then they're more receptive to treatments. Next slide. So formulating a treatment plan to reduce fractures in people with CKD. We're going to start talking a bit about other medication treatments. Next slide. Again, this is just going over stages of CKD, additional evaluations that you may take into consideration before prescribing a medication. Next slide. So pharmacologic treatments, these are the ones that are approved in the US. Yes, there are other medications approved across the world. Europe, you may have different medications available, but this is what we can get in this country. Hormone replacement therapy for people, for women that are postmenopause early on. If they can take hormone replacement therapy, that's fine to do. We do actually have some women into their older ages, 70s, rarely 80s, that continue on their hormones, and they do continue to help the bones over time. And I say always it's an individual decision. I won't take it because there's family history of breast cancer, whereas other people, they're fine to take it, and it really does protect their bones for quite a while. But we say that you don't have to take hormone replacement therapy. We have other medications to protect the bones. So the selective estrogen receptor modulators, the raloxifene, and the new one, the trade name is Duobay. The bisphosphonates, the ones that originally came in the market, the alendronate, risedronate, abandronate, and then later on the IV zoledronic acid. IV abandronate is available too, but once IV zoledronic acid came on the market, that's what we use more of. The biologic osteoclast inhibitor, denosumab, it's an anti-REG ligand antibody. Again, we try to use the zoledronic acid before the denosumab. Parathyroid hormone, teriparatide, it was on the market for many years. We had free samples of it for years and years, up until a year ago, October, when it went off patent. There is a generic, I guess you would say, available. Recently, I had something to show up in my office for free coupons for that. PTH-related protein, abaloparatide. Abaloparatide and teriparatide are extremely similar, whereas if you've already had teriparatide for that 24 months of lifetime, you can't take abaloparatide on top of it because they are so similar. And then the biologic sclerostin inhibitor, romosozumab, it came on the market just last summer, summer of 2019. And it works well in the, I think there's another slide on it, but it works sort of like the, the trade name is Duobay. The biologic sclerostin inhibitor, romosozumab, it came on the market just last summer, summer of 2019. And it works well in the, I think there's another slide on it, but it works sort of like the, the trade name is Duobay. The biologic sclerostin inhibitor, romosozumab, it came on the market just last summer, summer of 2019. And it works well in the teriparatide and abaloparatide the first 6 months, but then after that, the next 6 months, it acts kind of more like the Prolia in inhibiting the osteoclast. Next slide. So selecting the pharmacologic treatment or not, it depends on the stages of this kidney disease, as we discussed. Next slide. So there isn't a logarithm that has been published back in 2018 to kind of help you determine which direction to go. Next slide.
We've got about 10 minutes left, Julie, just on time.
Okay. So this is it. Of course, I won't go in this in detail. You can look at it on your own, but this is what has been published, and I think it's good to have a reference of it. Next slide. So in stages 1 through 3, treatment doesn't differ that much from the general population in determining which medication to use, but if the patients are in CKD 4 or 5, of course, you're using the medications off-label. They have not been approved for that. There was a post-hoc analysis that shows the efficacy and safety over 3 years of recidronate, allogenate, and raloxifene, and denosumab down to GFRs of 15, and so we can use them that low, but again, you got to look to see, is it really benefiting the patient or not. Teriparatide we can use down to a eGFR of 30, but in CKD5, again, we can't use these medications more. It's controlling the calcium, vitamin D levels. Next slide. And oral bisphosphonates are not recommended in patients with a creatinine clearance of 30. This is based on labeling of both US and European labeling instructions. Next slide. So the FDA labeling, let's go on to next slide. And this shows the mean changes in calculated creatinine clearance from baseline over time. Zoledronic acid does not reduce the creatinine. I'm telling patients that we're going to check their creatinine before, and they automatically think the medication is going to hurt their kidneys, when in fact it does not. I'm telling we just have to make sure that your kidneys are functioning well enough to take the medication, and they do fine. There are some patients that if their creatinine clearance is getting on the lower side, we might give them half a dose. We might dose it over 30 minutes. And also, of course, we tell all the patients to make sure that you're having 2 to 3 glasses of water before you come in for the infusion to prevent that side effect. And another thing on, next slide. I want to really strongly enforce, I see a lot of people that had side effects to zoledronic acid. They say, I'm never taking that medication. And again, when in fact, when I recheck, if their calcium, if they didn't have adequate calcium intake by supplements or diet, and if they've had low vitamin D levels, those are often the reasons that people are having the reactions to the zoledronic acid. Next slide. So proper dosing is the 5 milligrams over 15 minutes. But like I said, the duration can be extended to 30 minutes. Next slide. And again, we use the Crawford-Gault method to determine not just what's reported on the lab, but we actually do the calculation of Crawford-Gault to determine what their level of creatinine clearance is, to determine if they're going to tolerate the medication. And this just shows also that with those with placebo versus recidronate, they were tolerated. There are rarely patients that they will prescribe recidronate very low dose to help their bones if they are having high bone turnover with their CKD. Next slide. So denosumab, again, it inhibits rank ligand. You have to be careful about it in CKD5, but if they have CKD3 approaching 4, we can use it. And there are patients that we will use this instead of the raloxifene, I'm sorry, the zoledronic acid 4. Next slide. And it is very important with the denosumab to not skip the every 6 month dosing. Due to the pandemic recently, there were some institutions that were not giving it every 6 months. There were some patients that were so afraid to leave their house that they did not go in to get their denosumab. But we as a department sat down right away and said we cannot miss these every 6 months doses. We actually came up with a dot phrase by Epic to tell patients you have to take your doses every 6 months. At least 7 months, but if you're getting out to 8 months, these people do have rebound fractures, and I actually saw a person yesterday with this. Next slide. Teriparatide, again, these are daily injections, and these CKD patients, if they have a low bone turnover and you're trying to stimulate the bone turnover, these are good, but a lot of these patients, when it comes to doing a daily injection, they may have difficulty with this. And getting it is not approved by Medicare, so we're having to give these people samples. Next slide. Next slide. And again, it's considered off-label use in CKD4. Next slide. Abaloteratide stimulates bone turnover. I talked about that before. Again, if you have severe renal disease, though, we can't necessarily use it because it stimulates PTH, increases parathyroid hormone, and that's already a problem with chronic kidney disease. Next slide. Romosozumab. So Evenity, if you're not familiar with this medication, it came on the market last summer. It's 2 injections, 1 in each arm, once a month for a year. They saw excellent results with this medication. If a person has had an MI or stroke in the past year, they recommend not giving that, but if you're beyond the year, you're fine. I did have a person recently, though, she has recurrent TIAs, so we forego its use. And if they can't get to the clinic for those injections once a month, again, it's not a treatment of choice. They can't adhere to it. And you do have to monitor for hypocalcemia, again, in this medication as well in those patients with chronic kidney disease. So it's not the answer for all either. Next slide. Next slide. Okay, so let's talk about our person. As a person, so with the renal insufficiency, they have headaches, edema, low GFR, anemia. They just generally don't feel well. So next slide. So we have to talk about weight-bearing exercises. So a lot of these people just want to sit. They just don't feel good. But honestly, weight-bearing exercises is standing. Anything else I tell them is weightlifting. So if you can at least get them to stand for 5-10 minutes a few times a day, that does help the hip bone density, less likely to fracture. You don't have to go to the gym and do a lot, but just something. And we actually have in our folder that we give all the patients, we do have the nutrition tips and talk about things that can cause you to fall, poor vision. We talk about hazards in the homes, look at their list of medications, talking about not wearing shoes down a steps, make sure that you wear non-skid shoes, and having those lights. Those are the most common thing. People get up to go to the bathroom at night and trip over their bed, they stub their toes. So having night lights on. Next slide. Next slide. And so that's the conclusion. Now the questions are all that's left. Those are just for later on, I believe.